ccsradio.com. And as promised, Dr. Andrew Billon joins us in the studio. Our conversation is brought to you by Marcus & Mack, voted best personal injury law firm in the Best of Indiana County contest. Marcus & Mack, a law firm representing injured people. Dr. Billon, good morning.
Good morning, Todd. Good morning, Indiana.
It's good to have you back with us here today as we talk about a very important topic, colon cancer. This is Colon Cancer Awareness Month. And you deal with colon cancer in a couple of different ways. First of all, as a surgeon, and second of all, as somebody who tries to prevent colon cancer through procedures such as a colonoscopy. And that screening is probably a good place for us to start today because it's Colon Cancer Awareness Month, and folks need to be aware of how important that screening is.
So to highlight on the importance, despite our best efforts, colorectal cancer continues to be the second leading cause of cancer deaths. Sure, over the past 20 years, we've seen some decline in death rates, but last year alone, we had 153,000 cases of colorectal cancer alone. But we know that the American College of Surgery has recommended that first colonoscopy, no matter symptoms, is now age 45, no longer age 50. Part of the reason for that is that although we're seeing a decline in colon cancer rates in people over 50 years of age, the surprising thing is that we're seeing a very significant rise in colon cancer in people under 50 years of age. And a few months ago, I had to do a fairly aggressive colon cancer operation on a 36-year-old. And that was an eye-opener, I think, for a lot of us. But as we talk about risk and early detection, because let's face it, none of us want to face chemotherapy. None of us want to face surgery. None of us, frankly, want to have that diagnosis of colon cancer. And it's pretty astounding how easy it can be to avoid getting a colon cancer. We can do much better than we have. And it falls under early detection. Yes, we know risk factors increase, especially over the age of 50. Family history is important. A personal family history of colorectal malignancies, polyps, ovarian cancer, ulcerative colitis, and Crohn's put us at higher risk. Certainly alcoholism, high-fat diets, obesity are things to consider. But the thing I'd really like to hammer in the short time that we have here today, Todd, is symptoms, early symptoms. There are no symptoms. And that's the scary thing. Sure, if you have a change in bowel habits, blood in your stool, fatigue, weight loss, vomiting, change in your bowel caliber, bloating, cramping, diarrhea, you should be under the care of your physician who should help you navigate those issues. But specifically, where we can make a big difference is in those patients who have no symptoms. And obviously, regular medical checkups are important. A physical examination is important. If your physician, for some reason, neglects or doesn't offer to do a colorectal examination, check for blood yearly, that's vital. You should ask for it. We all know about fecal occult blood studies. But one thing that's come up are the Cologuard tests. And the Cologuard tests have caused a lot of confusion. Some folks, even physicians, see Cologuard as being a replacement for a colonoscopic procedure. It is not. Cologuard is an adjunct to surveillance, and it can be very effective. I see a lot of patients who are Cologuard positive. Roughly between 35 and 45% of them, we find nothing on colonoscopy. Mm-hmm. And that's worrisome because then you think, well, what does the future hold? I mean, greater surveillance, medical contact, and understanding things, communication with your physician. Sure, they're very important. But colonoscopy remains the mainstay for early diagnosis.
You have talked in the past about ways to prevent those polyps from forming, ways to prevent colon cancer from being a part of our lives, and dietary is a really big part of it. The last time you were here, you were talking about the Mediterranean
Yes.
diet, but diet is something that everybody can get a handle on and actually improve their chances of avoiding colorectal cancer.
Considerably. So let's take that 153,000 patients from last year. We can today, by what we know today, ascribe 15 to 20%, and that's a high number, of those cases being related to genetics. But what about the balance? I mean, there's some studies out there that say as much as 55 to 60% of colon cancers fall on modifiable risks. And we know that beyond diet, which we'll touch again on in a minute, we know that regular physical activity. I used to tell my patients, well, 3 times a week, and then it was 5 times a week. And then what happens is, well, did I exercise yesterday or the day after? So now what I recommend is every day, 10 to 20 minutes, every single day, do something. We all put on a little bit of weight over the Christmas holidays. It's incumbent on us to take that all off as the weather changes and improves. But other risk factors that we don't talk about as much, and we probably should, is alcohol consumption. The latest in alcohol recommendations, safe alcohol, quote unquote, safe alcohol consumption, is that no amount is safe just because of the way alcohol is metabolized in our system and the poisons that result. So alcohol is a risk factor for colorectal cancer, among others. Tobacco, without question, is a major risk factor for colorectal malignancies. But diet is one thing that we have a choice, and we make that choice every single day, 3 to 5 times a day. Diet is profoundly important. Higher fiber diets, the more color, the better in your vegetables. Fresher is better. Not so long ago, I used to say to my patients, well, organic doesn't really matter that much. Now, organic foods seem to make a difference. We have local vendors that, if not organic, they're very close to organic for your meats. But I have to say again, it seems, and there's a lot of literature out there, that a Mediterranean diet does translate into an improved and longer quality of life, and that goes with fewer malignancies in general, not just colorectal cancer. So most of us have Netflix, and there is a program on Netflix. It's called, I believe, Blue Zones. It's by Dan Buettner, who's the original author of those 2 books. He's identified societies worldwide that have the longest, highest quality lives, and what they do, what are the common denominators of things that they do to enjoy a longer, healthier, more vigorous life. And if you're not a reader, which sometimes it's hard in our busy society, certainly it's on Netflix for our consumption. So
I want to come back to one thing that you said, but I want to get first to this. If we don't detect it in time and we actually do develop colorectal cancer, IRMC with robotic surgery has found a way to make that diagnosis not as scary as it once was.
Yeah, the colon cancers that we are seeing are, I'm almost reluctant to say, perhaps less advanced than they were 10, 15 years ago. With what we do robotically now, Dr. Clark and I, our patients, we typically I'll do a resection on a Tuesday, and very often those patients are dressed, ready to go, wanting to go home Thursday on the second postoperative day in the morning. Obviously, we don't push anyone out the door ever, and if there's any reason to think anyone should stay longer, then obviously we keep them longer. But we used to keep them in the hospital 10 days longer. We see less bleeding, much less postoperative pain, smaller incisions. And we also have a relatively new technology that Dr. Clark and I have been employing since 21 that has shown dramatic improvement in leak rates. When we talk about removing a portion of the bowel or the colon, we rely heavily on technology and staplers and even hand sewn connections. Well, these connections, whether they're done by stapler or by hand, have an inherent leak rate. And those leak rates, depending on where you are, can be as high as 20% or as low as 1%. The national average for people who do a lot of this kind of surgery is around 5 or 6%. And we've shown that in over 100 cases, we've decreased leak rates from 5%, 5.5% to 1%. In fact, our first minor leak was at about number 104. And these papers are just getting published. It's taken some national interest. And so my point is that we afford our patients the latest in technology and to try to ensure a rapid recovery and a safe recovery.
Dr. Andrew Billon, our guest in our studio this morning, we're talking about colorectal cancer and how deadly it can be, but also how absolutely treatable and beatable it is. That's the phrase that is used a lot in terms of colon cancer. One of the things that we talk about is the removal of polyps, which is something that you do in a colonoscopy. When you find the polyp, you get it out of there. People who have had polyps removed in the past, more likely, less likely, no difference in the tendency to develop polyps in the future?
So when we identify a patient with a polyp, we remove it, we have it tested under a microscope. Depending on the type of polyp that it is or what it took to remove it, it'll dictate when you have the next colonoscopy. Some polyps will grow like a carpet, which are particularly frightening. It's technically more difficult to remove. The recurrence rates are higher. And so early detection is everything. We know that certain polyps, if allowed to go beyond 3 or 4 years, which happens very quickly in all of our lives, they will become a malignancy. So it's vital to identify those patients. Now, to answer the question, yes. When we identify a patient who has either one polyp or multiple polyps, they go through a period where they are at greater risk for developing polyps. And so we put them on a more aggressive follow-up schedule. And once that starts falling off, then we drop back depending on I've had patients who I've taken out 3 or 4 polyps 1 year. A year or 2 later, we'll remove 3 or 4 or 5 more. We don't let those patients go. We know that depending on the type of polyps that they have, they are at risk. But what happens then ultimately, for an inexplicable reason, they'll drop off in terms of the frequency of their or the aggressiveness of their polyp formation. We don't have an answer to that, but for instance, if somebody is on an every other year because they have a regimen, because they have an aggressive polyp, we'll do that follow for a couple of years until they start dropping off, and then we drop off to every 5 years for a while. But to your point, another important thing is most of our patients will be on a 10-year protocol. But what they forget sometimes is if a family member, mother, father, brother, sister, develops colon cancer, that immediately puts them into every 5 years. Mm-hmm. So they should not wait longer. The other thing I get commonly is, well, my grandmother, my grandfather passed from colon cancer. We do take it seriously. The current standards are we take more seriously if it's your mother, father, brother, sisters. But it does impact our way of thinking and does increase your presence on our radar clinically. And that's where Cologuard may come in. Mm-hmm. For instance, you may be on an every 5-year protocol, but maybe in 2.5 years we get a Cologuard. And if that's been negative in the past and it's positive at 2.5 years, then that again increases our awareness and will generate a colonoscopy.
Bottom line is those precancerous polyps, there's a reason they're called precancerous. You get them out of there before they become cancers.
Right.
Dr. Andrew Billon, thank you so much for the visit today. Folks want to make their colonoscopy screening appointment. That's easy to do. Just call IRMC, get on the schedule.
Thank you for the opportunity, Todd.
It is the voice of Indiana County. It's WCCS 101.1 FM, AM 1160, and WCCSradio.com. And the CBS Sports brought to you by S&T Bank, People Forward Banking.